This is Frank Sheeter. I'm a healthcare lawyer, and I'm the author of the Healthcare Compliance blog that you can find at www.thecomplianceblog.com. I'm going to be doing a series of healthcare enforcement and litigation and compliance presentations. This is the first one, so this is the introductory one, the first one of the new year and a new medium. So please give it a view and a listen and let me know what you think. Let's talk about the current environment. First, there's a lot of uncertainty right now. We have reports in the press about what healthcare reform means and what it doesn't mean. We have Congress, of course, in the efforts right now to discuss healthcare reform. The Republicans are trying to repeal and replace. There's economic pressure on the feds as the baby boomers age and more folks become eligible for Medicare. There's also economic pressure on the states as they try to fund an increasing number of Medicaid beneficiaries, and of course the states fund that through matching funds with the feds as well. So there's pressure on Medicaid on both the federal and state level. We've got politics, as I said. The Republicans are saying repeal and replace. They probably don't have the votes in the Senate to do that, but they are also vowing to defund and to expose the problems with the healthcare reform package. At the same time, you have the Democrats saying this is an opportunity for them to showcase the good things that have already happened in reform and that will continue to happen and that will go away if the Republicans have their way. Public opinion for the reform is low right now, and it's diminished since it was passed. That's notable because not much has happened under the reform. Not many of the provisions are now effective, and not many of them have had a substantial impact on citizens, but yet public opinion is falling. I mentioned the aging population and the continuing cost spiral that will cause. There's an emphasis on quality, and quality is often talked of in terms of pay for performance, but from a provider standpoint, it sometimes feels like non-pay for non-performance. And the government, in fact, has come out with studies showing the money that they will save with pay for performance. So again, we lead to the concept that there could be non-pay for non-performance if providers don't have adequate quality outcomes with their patients. And then we have reimbursement pressure on providers, both physicians and hospitals. That is an ongoing challenge. We have new and tougher laws. For example, the False Claims Act was amended by FARA, the Fraud Enforcement and Recovery Act of 2009, to make it more government-friendly and more whistleblower-friendly and tougher for entities that were accused of false government claims to defend themselves. Of course, the healthcare reform package as well made the False Claims Act even more user-friendly and more difficult for defendants. In one specific way, the report and repay language in the False Claims Act that came in under the healthcare reform package indicates that a provider will have potential False Claims Act liability if it has an overpayment that it has identified but fails to report and repay that overpayment within 60 days of having identified it. That compresses time periods for an investigation, and it can turn the innocent receipt of overpayments into False Claims Act liability. We have encouragement of whistleblowers by Congress, and of course with the user-friendliness that we now find in the False Claims Act. The anti-kickback statute has been amended as well. The intent standard has been diminished, so you don't have to have specific intent to violate that statute. And of course, a violation of the anti-kickback statute can be a violation of the False Claims Act as well. We also find that a Stark violation can be a violation of the False Claims Act. And we have the anti-kickback statute and Stark law not really softened in any way to allow for some of the new models that the healthcare reform law promotes, like the accountable care organizations and other vehicles that are supposed to lead to better collaboration among providers and greater efficiencies. And then we see more enforcement on the Medicaid side. As I said, there are more and more Medicaid beneficiaries. A lot of the new recipients of health care insurance under the health care reform package will go into Medicaid plans at the state level, Medicaid has been an area that has largely been untapped as far as enforcement goes, and we see more and more state false claims acts, and we see very aggressive state inspector generals, Medicaid fraud control units, and attorney general's offices at the state level going after Medicaid fraud. We see an enhanced enforcement agenda at both the state and federal levels. Basically, we see recoveries of overpayments, whether they are innocent overpayments or fraudulent claims. We see recoveries from those offsetting rising costs in the healthcare delivery and reimbursement side of things. We see joint efforts by HHS and DOJ. We see joint efforts between the federal and state governments. We see joint efforts among different agencies of the state and federal governments. And we see joint efforts among commercial payers and government-funded payers. There's a push for immediate results. If you look at the government's HEAT initiative, for example, which is the joint DOJ, HHS anti-fraud initiative, you see that the Secretary of HHS and the Attorney General of the United States are going out touting the HEAT initiative and the recoveries that they're making. At the state and federal levels, we see enforcers and regulators pushing cases through towards more prompt results than they have in the past. We see data prospecting. I call it data prospecting because the government is using data to figure out which providers to look at. They don't start with an allegation against a provider, but rather data to say, gee, where should we look? We see an increased focus on relationships between hospitals and physicians, and we've seen recently some large settlements in the millions and tens of millions of dollars relating to physician-hospital relationships where there's an underlying allegation of any kickback violations or Stark violations. And we see the OIG focusing on individual accountability, and we see exclusion language in regulations suggesting that individuals will be held accountable for the noncompliance of their organizations. How do these government initiatives get implemented? First of all, we have the HEAT initiative that I just mentioned, and you'll see a resource at the end of the presentation that points you to the website for the HEAT initiative. You have RACs. You have Medicare RACs being extended to all 50 states, all regions, and the RACs are paid on a contingent fee basis. They're recovery audit contractors, and they're paid to find overpayments made to providers based on inadequate documentation or lack of medical necessity, and to return that money to the FISC. You've got the Medicaid RACs that were supposed to be contracted by the end of 2010 and are mandated to start audits of Medicaid claims by April of 2011. They're also paid on a contingent fee basis. You have ZPICs, the Zone Program Integrity Contractors, which are aimed at preventing and detecting fraud early on. They have sweeping powers, and they've been very assertive so far. You've got MICS, the Medicaid Integrity Contractors, who are also going out and trying to identify improper payments to providers on the Medicaid side. Again, you have data prospecting by the government at the state and federal levels so they can identify target-rich environments that they can then go after for improper payments or alleged improper payments. In other words, they look at claims patterns, they compare providers, they find out who's sticking out, and they pay a visit or make a request for information to that provider. And finally, you have national initiatives. The biggest one right now is the implantable cardioverter defibrillator investigation that is being handled by the Department of Justice out of both Washington, D.C. and Miami, and we'll talk about that specifically in a minute. What can providers do? Well, first of all, they can assess their compliance efforts. They can assess the resources devoted towards compliance. They can more tightly focus their compliance initiatives and activities and undertake to determine whether they have effective compliance programs that will actually catch potential problems before they become major risks to the organization. The board should be involved in compliance. That's what the Inspector General is saying. That's the current expectation. The board should know what's going on. The board should be dedicating resources and time to addressing compliance concerns. Providers should have response teams, and they should be broader than just RAC response teams for hospitals. They should be government audit response teams that address the alphabet soup of audits that we discussed in a previous slide, a couple slides ago. These government audits may take different forms, and they may be initiated by different players, but the bottom line is that these agencies and contractors are trying to recover money from providers. You need a consistent and unified and multidisciplinary team to handle that. You should target specific areas. Certainly look at the OIG work plan, look at the semi-annual report. There are links to those at the end of this presentation. Look at what you've had weaknesses on before. Look at what your neighbors and peers are getting in trouble for, and look at the high-risk areas that have high dollars associated with them in planning for your compliance auditing and monitoring. And let's talk for a minute about prevention versus rationalization. Prevention is hard to commit to. It's hard to sell. It's hard to get buy-in. But preventing problems as opposed to getting involved in a government investigation is always cheaper, easier, and less disruptive to the organization. It's hard to rationalize, this won't happen to us, we're an ethical organization, we do things the right way. The healthcare reimbursement system is Byzantine. It has myriad rules which are very hard to follow and very inconsistent and subject to different interpretations. And the government is taking very strict enforcement views. So waiting to be in a reactive posture now more than ever is not the best strategy. What are the specific risk areas for hospitals? Well, first of all, implantable cardioverter defibrillators, or ICDs. As I said, there's a national investigation going on by DOJ under the False Claims Act, wherein it has sent out letters to hospitals across the country indicating that the government believes that the hospitals may have submitted claims for ICDs without following a national coverage decision that has certain payment windows and criteria in it. This is a fraud investigation under the False Claims Act. It's widespread. The government representatives are assertive, and the reimbursement can be $40,000 or $50,000 per ICD. This is one worth checking into. I will do further presentations and have some additional material about this if you're interested. Short stays, again, stay on the list. One-day stays, observation. Those issues are nagging and perennial issues for hospitals. Chest pain is another one that is taking shape as an enforcement area and an audit area. High-dollar RAC issues. Again, look at what the RACs have approved as issues in your region. There are probably too many for you to hit them all consistently, but look at the ones that are high dollars and look at the ones where there has been a lot of press or where there is an explicit standard that the RAC can use to recover money easily against providers. Medicaid, again, we've traditionally focused on Medicare. That's changing. The landscape has changed such that you now have to be equally as focused on Medicaid reimbursement and the rules there, because as I said, the states are picking up steam and enforcing aggressively. That will continue, and unfortunately we don't always have the internal and external resources to address Medicaid reimbursement issues. We have to develop that expertise to succeed in the current and coming environment. And finally, contracts with physicians or not. We see still that many organizations, many providers do not have their contracts with physicians in order. And as I said, we see some very large settlements and investigations coming out of those documentary failures. Of course, we have CMS having issued a Stark Voluntary Disclosure Protocol. Again, if you need more information on that, we have other material on that, and that may be the subject of another one of these presentations in the near future. So that's a quick overview. The idea is to keep these short and to just give you a quick dose of what's going on out there. As I said, this is the intro one. For more information, you can look at the materials cited on this further info slide. And of course, you can email me or contact me if you would like further information